And I'm happy to introduce our first speaker for this morning, Dr. Larry Latson, who is an assistant professor in the Department of Radiology. He's going to talk to us today about radiologic tests for lung cancer. Let's welcome Dr. Latson.
Good morning, everyone. Thank you, Rachel, and to the Cancer Center for inviting me here to speak. For the next few minutes, I'm just going to talk a little bit about some of the different radiologic tests that are commonly used for lung cancer, both for detecting lung cancer and for follow-up of lung cancer after treatment. And Rachel passed out cards to everybody, so if you have any questions, please feel free to write them down, and then we'll discuss them at the end in the panel discussion. So in the talk today, I'm going to go over a little bit about lung cancer. I think the other speakers are going to cover that in more detail. And then I'm going to talk about the three main modalities that we look at lung cancer with, and those are chest x-rays, CT scans, and PET CT scans. There are many others, which I don't really have time to go into today, but these are some of the big ones. And I'll talk a little bit about the tests themselves, what information they can give us, how they're performed, what the machines look like when you're actually having the test, that kind of stuff. And then at the end, I'm going to touch a little bit about radiation dose of the different tests that we use. So I thought I'd start off with the first question. And the question is that chest CT is superior to chest x-rays in the detection of lung cancer. Is that true or false? Chest CT is better than chest x-ray. True or false? So I'll give everyone just a little bit of time. And so it looks like most people said true, and that's correct. So chest CT is better than chest x-rays at detecting lung cancer. And I'll give you some examples of why that is in a second. The next question I had was, most lung nodules are due to lung cancer. Is that true or false? Okay, good. And so I'll give everyone a couple more seconds. And so the answer is false. So as a chest radiologist, I spend my entire day looking at lung nodules. And it's a very rare scan that has no lung nodules at all on it. So most lung nodules that I see during the course of the day are not lung cancer. And I think that's an important thing for people to know. That doesn't mean they don't need follow-up or that certain nodules don't need further investigation, but the vast majority of nodules that we see are not lung cancer. All right, so a little bit about lung cancer. It's the leading cause of cancer-related death in both men and women. It's more deaths than breast, prostate, and colon cancer combined. And the most important risk factor for developing lung cancer is a history of cigarette smoking. But non-smokers can and do develop lung cancer. This is just a nice graphic showing the rates of diagnosis of lung cancer on the left-hand column. So more people are diagnosed with prostate and breast cancer than lung, but more people die of lung cancer than prostate, colon, or the other cancers combined. So it's a deadly problem. So this is the first and most basic test that we use in radiology. This is the chest x-ray. This was invented back in 1896, so it's been around for a long, long time. And this is what it looks like when a patient has a chest x-ray. They stand. Let's see if I can use my cursor here. Can you see that? So the machine is here, the patient stands here, and there's a detector right in front of the patient. The x-rays will come out of the machine, pass through the patient, and hit the detector, and then make the image that we see here. And so the black that we're seeing here is the lungs, the white thing in the middle is the heart, and you can see the bones and the ribs. The spine is in the middle. And we usually take a chest x-ray, we take a frontal view, so this is looking straight through the patient, and then we take a lateral view, which is looking through the side of the patient. And the advantages of chest x-ray are that it's very quick. There's no preparation, and it can answer some clinical questions very quickly. So questions like, do you have pneumonia? Do you have a pleural effusion? Things that you don't really need advanced testing to diagnose. And it's very cheap, and it's very low radiation dose. But there are some disadvantages, and the big one is that it doesn't really give fine detail in the lungs. So if we really want to get better detail of the lungs, we use this test, the computed tomography scan, or CT scan. Some people call it CAT scan. They all mean the same thing. So this is the CAT scan machine. It's a donut sort of looking thing. The patient lies on the table, and the table will move in and out of the machine as the patient is scanned. CT images are generated also using x-rays, but not just one x-ray. It's many x-rays taken at all angles around the patient. And then we use those different x-rays to generate an image that looks like this. So this is a slice through the top of the patient. These are the lungs. So these black areas are the lungs. This is the aorta and the mediastinum where some lymph nodes live. This black circle here is the trachea, the main airway to the lungs. One of the quirks of radiology is that our images are flipped. So when you're looking at an image in radiology, the right side of the patient is on the left side of the image. So this is the patient's right lung, and this is the patient's left lung. It's sort of a funny convention that was established a long time ago. Most CAT scans that we do for lung cancer don't require intravenous contrast, but some of them do. And if you don't require contrast, there's really no preparation for this scan. You can walk right in with your shirt on, just lie on the table and get the scan and pop right off, and that's it. If you do need contrast, there's a little bit more preparation for that, which I'll show in a second. So what kinds of things can we see when we do an x-ray? These are 3 different patients. This patient has a large pleural effusion here, so all of this white stuff underneath the lung is a lot of pleural fluid. This is fluid around the lung, not inside the lung, but around the lung. And then these 2 patients have these big opacities in the lung here. This is the left lung here, and then here's another one here. And so one of the disadvantages of x-ray is that I can see these are here as a radiologist, but I can't tell, is that a cancer or is that a pneumonia? I can't really make that determination just from this image alone. That's something that needs further investigation. Here's an example of why CT scans are better at looking at the lungs than chest x-rays in general. So this is a patient who had a chest x-ray. Does anybody see anything abnormal here? Looks pretty close to normal to me. But then this is the CT scan that the patient had a few months later, and everybody can see this big thing here. This is a big lung cancer. So this is a large adenocarcinoma of the lung, which is almost impossible to see on the chest x-ray. So this is one of the advantages of CT scans. Here's another example. I still almost can't believe this case. Looks like a normal chest x-ray to me. But when the patient had a CAT scan, clearly there's a very large nodule here, which turned out to be lung cancer, which should be somewhere here on the image, and I can't see it. Here's some more examples of different types of nodules that we see. Sometimes we like to characterize the nodules as either ground glass nodules or solid nodules, and sometimes those have implications for what type of cancer this might be, if it was a cancer. So I talked a little bit about what to expect when you're having a CT scan. Often you don't need IV contrast. Sometimes your doctor will order the scan with IV contrast, in which case we have to do a couple of things. Usually we have to make sure your kidney function is okay. So we're going to give you iodine contrast. We have to make sure the kidneys can handle that and excrete it okay. Usually you have to fast for a few hours before the exam. That's because sometimes patients get nauseous when we give them the IV contrast. It's usually very quick. It passes quickly, but we don't like people to throw up when they get the scan, so we ask them not to eat for a few hours. And it's important to report any allergies that you might have to the radiologist or to your doctor before the scan, because you might need some pre-medication to prevent an allergic reaction when you get the test. And unlike MRI, even patients with claustrophobia generally tolerate CT scans very well. It's like I said, the machine is a donut. It's open, and you slide in and out very quickly, as opposed to an MRI scan. I don't know, probably some of you have had some MRIs. They're much more enclosed and a little harder to tolerate. CT scans are very quick. They're usually done in the single breath hold, so the machine will ask you to hold your breath. You'll move through the machine, and then it'll be done, as opposed to an MRI, which can take 30 minutes or 60 minutes or more. All right, and so what do we look for when we get these scans? We talked a little bit already about nodules. Nodules, the most important thing that we look for in nodules is whether they're growing or changing over time. So they can grow quickly or slowly, and stability is a good thing. So if the nodule is not changing over time on follow-up exams, that's a very good thing. It means it's unlikely to become a problem. Let's see, we like to see at least 2 years stability for solid nodules. If they haven't changed in 2 years, then we like to call them benign. Some of these nodules that I showed you before, the ground glass nodules, usually we need to follow those for longer just to make sure they don't change. And then we look at everything else, not just the lungs when we do a CAT scan. We look at everything that's in the chest, and that's the airways, the lymph nodes in the mediastinum. We look at the blood vessels coming in and out of the heart. We look at the bones in the chest wall, everything that we can see. And what are we looking for? Well, as a radiologist, I can tell you, especially in patients who have had a history of lung cancer or surgery or chemotherapy or anything like that, the most important study for us is the prior study. So like I said, we're looking for things that are changing, things that are new, things that are getting better or getting worse. I think that's one of the most important things that we look for. And so having prior studies available really helps us decide whether what we're seeing is normal or abnormal. Okay, what does a radiologist do? What do I do every day? How does this work? So after you get your scan, your images are sent to our PACS system, which is kind of like a big hospital archive, contains all the images for all the patients at NYU. The images come to me in a computer, and I look at the images. I compare them to any prior studies that you might have had, and then I dictate a report with all the different findings that I see, and I formulate an impression, which is sort of the highlights. So I can talk about all the different things I see. They're normal, maybe slightly abnormal, and then in the impression I try and give just the big picture, the most important thing, so that the clinicians can read that and know which way to act for the patient. If something is found on the CT scan, what happens? Well, we do our best to characterize nodules that we see as benign or probably benign. Sometimes we're not able to do that, and we have to call nodules either indeterminate or maybe malignant or definitely malignant. And the more worrisome they look based on the CT scan, the higher likelihood that you'll either need a short-term follow-up imaging or that you might need to go to some other intervention right away, like a biopsy or surgery. There are lots of guidelines that we use in terms of these nodules. This is not just sort of gut feeling of the radiologist. This is all well-researched stuff, and so we have very specific guidelines of when we see a nodule of a certain size with these certain characteristics. We have guidelines for how to follow that up, what the likelihood that is of becoming cancer, and so we can put in our reports, this is best followed up in 3 months, or this is safe to follow up in 12 months, something like that. And again, I want to stress this, most nodules that we see are not lung cancer, and a request for follow-up on a CT scan does not mean that a nodule is lung cancer. That's a very important point. Okay, again, so just pounding it home. Okay, if the nodule is big enough, when we find a nodule, usually something around the size of a centimeter or larger, so the size of your pinky nail. If it's that size or larger, then we may need to go on to do something right away to find out what this is. And one of the most common tests that's used for characterizing these larger nodules is a PET CT scan. So I'll show you, this is a PET CT machine. This is actually 2 machines in one. It's a PET scanner, which is a positron emission tomography scan, and a CT scan, which is what we were looking at before. And the PET part of the scan, we inject you before the scan with a small amount of radioactive dye. It goes into your blood about 60 minutes before the test. You sit quietly, and this dye sort of mimics sugar, and sugar is the main fuel for your body. So anything that's really active in your body will take up this dye and will turn out bright on the PET CT scan. And the idea is that tumors are usually very metabolically active. They'll take up a lot of this dye, and they will show up bright on the scan. Okay, so PET CT scans are not used just for further investigating nodules, which we find. They're also used if someone has a new diagnosis of lung cancer to stage the patient. So maybe we find a nodule, we've determined that it is lung cancer, and then we have to decide what the next steps are, surgery, chemotherapy, things like that. You can use a PET CT to stage the patient, look for other sites of disease. Maybe the cancer has spread and surgery is not the right answer at this time, different things like that. And then we can use PET CT to follow up patients who are already being treated for lung cancer. So maybe you had a PET before you started treatment, and then you've gotten some chemotherapy, and then you might follow it up with a PET CT after that to see the response to the chemotherapy. Whoops. This is a little bit about preparation for PET-CT. Because we're trying to look for things that are metabolically active, we ask patients not to do any strenuous activity for a couple of days before the test, so no exercising, no weightlifting. Usually you have to fast for about 6 hours before the exam, a little bit longer. And then you get the injection when you come. You'll sit quietly in the room for about 45 to 60 minutes before you actually get on the PET-CT machine. And then once you're on the table, the scan itself is about 20 to 30 minutes. So this is a little bit longer than a regular CT scan, which is just a couple of seconds. All right. Here's an example of what a PET image looks like and a CT image looks like. So on the CT image, you can see this big round thing here. This is the lung cancer. And on the PET scan, this is all very bright. We call this bright, even though it looks dark. So this is taking up a lot of that radio tracer. This is very metabolically active, and that's consistent with the lung cancer. Radiologists now, these used to be separate tests that were done usually on separate machines on separate days, but now that we can put the machines together and you have one single machine called a PET-CT machine, you take the images together and you can create an image that looks like this. This is a fused image with the anatomy is coming from the CT scan, and then all of the orange that you see is coming from the PET scan. And again, you can see the lung cancer here right in the right upper lobe of the lung. And then other things you see, this is the liver, which is normally pretty active. These are the kidneys. All right. What else do we find on CT scans and these other studies that we do? So incidental findings are a big issue in radiology. This is a patient who's got normal lungs, and this is a patient with emphysema. So this is an incidental finding, but you can see all of these sort of black areas in the lungs. There's too much air in the lungs. This is emphysema. This is a patient who had a chest CT scan. This is the right kidney, and then this round thing here. This is actually a kidney cancer. So this patient was coming for a lung nodule follow-up, and we found a cancer in their kidney. Here's a patient who has a small nodule in their left breast. This is an incidental finding, but this turned out to be a left breast cancer. So we made a diagnosis of cancer there. And then lastly, I'm going to talk a little bit about radiation exposure. So all of these tests use radiation to varying levels. And these are the numbers that are reported often in the literature. These are very hard to understand, I think. This MSV stands for millisieverts. That's a very difficult concept. So what does that mean? Well, just walking around on Earth, you get about 3 millisieverts of radiation, background radiation, every year. So just walking around, living your life, every year you get 3 millisieverts. So a chest x-ray is 0.1 millisieverts. So that's 1/30th of an annual dose. A low-dose screening CT, like if you're going to get screened for lung cancer, is 1 to 2 millisieverts, so less than a year's worth. A diagnostic CT, at NYU it's about 5 millisieverts, so a little bit more than 1 year's radiation dose. And then a PET-CT is the one that has the most radiation. It's about 25 millisieverts. Okay, so I'm going to finish up by asking my questions again, but I think you all did excellent on the first round, so we don't need to do it again. Chest CT is superior to chest x-rays in the detection of lung cancer. This is definitely true, right? And then most lung nodules are due to lung cancer, and this is definitely false, right? Okay, thank you very much.